So welcome everybody to the first research seminar for the fall. Happy to see you here. Hope you had a nice summer. And today we start out with somebody who has visited us before and who is affiliated with the Institute, Per Molander, who's going to speak about public versus private healthcare system in the OECD area, a broad evaluation of performance. So Per got his PhD in something so interesting as control engineering from Lund a little while back, 79. And since then you have worked in many areas. You've been senior roles in Swedish government offices, Director General for the Swedish Social Insurance Inspectorate, and you share the Public Commission on Equality, which 2 volumes that came out that. I recommend you to read them. I don't think our present government had taken so much interest in it, I guess. But and then you've also been an advisor to World Bank, IMF, and OECD. So a very broad background. And as you mentioned, also some books you've written. You recently came out with this book, it's titled in Swedish, En invasiv art, så tog företag makten över världen, which you also had a book launch here for. And also another one is, the one I mentioned before this big report is A Common Concern, report from the Public Commission on Equality. There is an English summary for that, but otherwise I guess it is in Sweden, as you still use Swedish in Sweden. Anyway, the floor is yours. Very welcome.
Thank you. Thank you for the invitation. Well, as you have seen, the topic is about the borderline between private and public, and like all those issues, it's politically hot. And a lot of arguments have been produced for and against private solutions in this area, often ideologically based. About 1.5 years ago, I was invited to a conference, sort of rally around the flag against private insurance meeting. And my reflex was to look at the facts rather than join the choir, and see what can be said about this matter, private versus public solutions in the healthcare sector. So I took a look at the OECD data and gave a presentation, and then about a year later, in March this year, that resulted in a paper in the European Journal of Healthcare. What I'm going to do here is to give a summary and some sort of general reflections on this topic. The concept of private in this context is somewhat ambiguous. We have to specify what dimension you are thinking about, and there are at least 3 dimensions that are relevant. First, who's in charge? Sort of the administrative aspect. The second dimension is the financial one, who pays. And the third one is production, who produces services within the healthcare area. And my talk, as well as the paper, deals with the first 2 of these dimensions, which have been somewhat neglected in the literature. Most of the literature devoted to this problem deal with production. They compare private versus publicly offered healthcare services, often at the clinical level or hospital level, and come up with the results saying, for instance, private healthcare clinics in this area are 11% more efficient than public ones, and then it's up to the reader to draw the implicit conclusion that private healthcare is better than public. So my focus will instead be on the other two dimensions, administrative and the financial dimension, and compare the outcomes depending on what solutions you choose. Well, first some theory. More than 60 years ago, Kenneth Arrow published an often cited paper arguing that the private sector will never play any significant role in the healthcare sector. And his reasons were the ones you see on the left here. The demand is volatile, it's highly skewed. Some people are in need of a great deal of healthcare, others don't need any healthcare at all, practically. There is a strong information asymmetry between the producer and the consumer. The physician knows much more about the topic than the patient, normally. There's an adverse selection problem, and there are large transactions cost problems of surveillance and so on. So his conclusion was quite clear. There may be private healthcare, but it will never play any significant role. But of course, private sector capital owners and right-wing politicians kept pushing for more private healthcare supply, particularly in the United States, and eventually an alternative solution was presented, often coupled to the name of Alain Enthoven. And the arguments for private care in this sector are the standard ones about cost, efficiency, flexibility, innovation, and so on, where the private sector supposedly supersedes the public sector. And the problems that Arrow had listed should be manageable, according to Enthoven, using what he called a managed competition. That is, the state should be involved as a regulator of the healthcare market. The insurance, it has to be an insurance solution, should be mandatory, thereby avoiding the adverse selection problem. And so this is how the theoretical and ideological debate went on for quite some time. Within the OECD, if you look at OECD 50 years ago and OECD, it looks as if the private solution based on mandatory insurance has expanded, but that's something of a statistical misinformation. The reason why there are more private solutions today is because there are new member states. The OECD has expanded partly in Eastern Europe after the fall of the Soviet Union, where a number of new Eastern European states joined, and also in Central and Latin America. And in Eastern Europe, there was, of course, great skepticism about public solutions following half a century of communist mismanagement of the public sector. Whereas in Central and Latin America, this solution has a long history. So it's more of a historical heritage. We have seen very little movements in the sense of reform. Netherlands is the only country that has enacted a major reform based on this which happened in 2006, and that reform was evaluated 15 years later, that is in 2021. Also here in Sweden, as you know, there has been some tendency for private healthcare insurance to expand, but not as a result of a major reform decision, but rather as a sort of a tacit expansion of the private sector. often tied to employers. So employers offer healthcare supplements to the public insurance as a way of attracting employees. Well, how should you go about this problem? What do you mean by efficiency? We must define that, and we must define first the concept of output or outcomes and so on. What should we measure in order to get a grip on how the healthcare sector works? Well, this has been approached from different angles at the OECD secretariat now for many decades, and they have developed a statistical database which today comprises between 40 and 50 indicators of success. They also subjected this set of indicators to peer review in 2015, that is 10 years ago, and that led to some modifications. So now there are close to 50 indicators that belong to 3 different groups. What we would like, sort of the ideal solution would be to have an indicator, an aggregate indicator of success for the whole healthcare sector. And the first candidate that comes to mind is, of course, expected longevity at birth. That's a grand measure of how healthy a society is. But one soon realizes that this measure is affected by a lot of factors in society which have nothing or little to do with how the healthcare sector. I mean, culture, food habits, you can work life and so on. So they, I mean, you can imagine easily 10 or 20 factors that have some impact on this. Some people try to use such an indicator nonetheless, and then compensate for that by doing linear regression with some additional explanatory factors. Alcohol consumption, for instance, would sort of be an indicator of how healthy habits people have in a society. But I think we must be content with the fact that this is one, this type of indicator is just one out of several that you have to work with. Another would be infant mortality. It's another sort of grand measure of the quality of healthcare, often used in developing countries. The second category is outputs, and there you come closer to what the healthcare sector is actually doing. Vaccination programs, mammography, various operations, and how successful these are. I mean, what is the coverage of a vaccination program? Do you reach the whole population? That's success. If you reach 60%, that's a failure. And finally, you could look at resources. How many physicians are there per 1,000 inhabitants? How many hospital beds? How many intensive care beds, etc.? An objection to this third category is that this is not interesting. What is interesting is what you're actually doing in the health sector, not what resources you have. But this is nonetheless interesting, because if you are wealthy in this respect, you will be more resilient in case of major shocks, such as pandemics or major accidents and so on. The frequency of computer-based tomography, for instance, an indicator of how open the healthcare sector is to innovation. So this third category is also interesting as a measure of quality. as I said, these adds up to close to 50 indicators for which there are data now from most of the OECD member states, which are now 38 by number. But of course, data are lacking for a number of countries. They simply have not developed statistics enough, particularly among the middle-income countries that have joined more recently. So how should we use this set? Well, efficiency is, of course, some ratio between what you achieve and what resource input you have. And in order to produce an aggregate measure that you need for forming this ratio, I took the liberty to eliminate some of the indicators from the OECD set. For instance, no double counting. If you have longevity at birth as one indicator, you should not have longevity at 65, which the database comprises. The indicators should also preferably be unequivocal, and sometimes they are not. For instance, as you know, there is a tendency of overuse in the field of antibiotics, and so we have tried to impose restrictions here in Sweden and other developed countries, and try to sort of keep the consumption of antibiotics down. Now, in a poor country, you may also have a low consumption of antibiotics, but not because of restrictions, but because of lack of supply. And if you have this ambiguity, that's not an indicator you should use. And then third, the coverage should be sufficient. And I require that at least 1/2 of the member countries should be able to supply this statistical base, which eliminates a few of the indicators where there is a shortage of supply. Now, if you have, and that leaves 37 indicators after this cleansing operation, then you should form some sort of aggregate measure from these 37 indicators. And I've looked at two alternatives doing this. Again, one hypothetical alternative would be to try to use an economic measure to translate all these indicators into something economic, which would say add up to quality adjusted life years or something of that kind. But you soon realize that there is not information enough to perform this operation. So we'll have to do with these indicators, which are of course incommensurable. You can't add number of hospital beds to expected longevity at birth, and so on. So you need to form some artificial scale on which to measure these different dimensions. And the first simple one is to normalize all these indicators to the interval between 0 and 1. Where 1 is the best performance and 0 is worst. And then you get something that could be added from the average, and that's a sort of the aggregate measure of quality. An alternative would be to use rankings. If you look at the number of hospital beds, one country will have the largest number of hospital beds per 1,000, and another country the next largest, and so on. And you simply use this ranking from 38 to 1 as your measure and form the average of that. For those of you who are acquainted with voting theory, this is what's referred to as the border count, invented by Chevalier de Bourdin in the 1780s. There is no ideal solution in this field, but the border count comes as close to an ideal solution as you can. That was shown quite recently, actually, by Eric Maskin in February this year. So this is quite fresh, the support for board account. And of course, you do both these and compare the outcome, and it turns out that there is some robustness to the conclusions. The conclusions will not depend critically on what measure you choose of these two. So the program then will be first to estimate aggregate performance based on one of these two as a function of the healthcare budget. Of course, rich countries can afford better healthcare, so there is an obvious link between the healthcare budget per capita and the outcome. And then we should expect countries with roughly the same budget to perform more or less well. And those residuals that you compute from the first estimate will define efficiency. Now, if we look at the first question here, what should we expect as a relationship between the healthcare budget and the quality of healthcare? Well, if there were an optimal solution to the problem, the optimal healthcare system, and this information was known to everybody in the field, then it would be simple, because it would be a very nice, smooth curve, and the position of each country on this curve would be completely determined by its healthcare budget. Sort of one-to-one correspondence between the healthcare budget and the outcome. The other extreme would be that there is no relationship whatsoever between the healthcare budget and the quality of the healthcare sector. And then you have the shotgun picture, sort of chaos. Now, in reality, we end up between those two extremes. For the simple reason that everybody who is active in this field knows what are the best measures to start with. If you're a poor country, what should you do with your limited healthcare budget? Well, vaccination programs is efficient. Maternal care is efficient. Elementary primary care for other citizens is efficient. So you should have a rather steep relationship at the beginning. And then as the GDP grows and the resources to the healthcare sector with it, you will be able to raise quality, but at an increasing marginal cost. So what we should expect is a concave relationship between the healthcare budget and the outcome, which is what you see in this picture. This is the healthcare budget per capita in US dollars. US dollars adjusted for purchasing power and also age adjusted. The age adjustment is simple because the OECD has elaborated a simple transformation that sort of homogenizes populations across different age profiles. And here you have the average output measured using the first ordinal scale. So this is not the ranking, it's the ordinal scale. And you see the expected concave relationship. This is a logarithmic curve. The R2 value is about 0.5. And also as expected, if you pick one budget here, say $6,000 per capita a year, you can see that there are some countries below and there are some countries above. And the ones that are below are underperforming, and the ones that are above are overperforming. And this residual, sort of the distance between the country and the average performance, defines efficiency of the healthcare system in the country in question. So now we have prepared the ground for the first sort of administrative question. How are these residuals related to the solution, administrative solution, basically public or basically private? Now, of course, I should prepare you for the fact that there are no pure solutions in this field. There are no pure public solutions. There are no pure private solutions. They are all hybrids. And so we'll see points on a scale rather than in one single point. And this is a nice picture. You see two clusters here, which are fairly obvious. And the horizontal axis here measures the ratio, the share of governmental solutions. So here at the right end, you have countries with basically public healthcare systems. The Nordic countries, the United Kingdom, Australia, Canada, and a few others. And to the left, you have the basically private solutions based on mandatory insurance, but insurance that is supplied by private companies. The regression line here slopes weakly upwards, which indicates that the public solution would be slightly more efficient than the private one. But the slope is, of course, not significant. You can see that with your naked eye. So the first conclusion is there is no average difference in performance between public and private solutions as far as administration goes. What you do see, however, is that the spread in the private cluster is much greater, which means that this is an uncertain way of solving the healthcare supply problem. And if someone were to choose with a clean slate a healthcare system based on this information, you should opt for the right-hand side, because even if the expected value is about the same, this spread here makes the expected welfare of the left-hand solution much lower, because welfare is also a concave curve of consumption, as you know from welfare theory. So this left-hand solution is riskier. And of course, you have the horror here in the diagram, the United States at the very bottom, which has by far the most expensive healthcare system in the OECD group, but which produces services basically on the same level as Turkey or Colombia. So this answers the first question. You can choose whatever administrative solution you want. The expected value is the same, but then taking notice also of the spread on the left-hand side, you should opt for the right-hand side if you start from scratch. The policy question is, of course, what are the arguments for reform based on this diagram? Well, if you're on the right-hand side, there are virtually no arguments for moving leftwards, because what you do is you increase risk. If you're here, well, you could reduce risk, but on the other hand, reform in itself is a risky project, and so I wouldn't say that, for instance, the Netherlands or Luxembourg or Greece even should move towards the public corner of this diagram. If you are down here, perhaps Lithuania, Poland, Mexico, and definitely the United States. But of course, in the United States, that will not happen. The second question is about financing. And this will give a radically different picture, because what's called here administratively a private solution is an insurance solution where a lot of public money goes into the private companies supplying these services. So if we go to the OECD database and pick out financing schemes instead, and sketch the same diagram, but with government financing share here at the horizontal axis, we get a different picture, which is this one. You can see here, for instance, that, well, a lot of public money goes into to these systems independently of the country. Only Switzerland is below 50% public money. And public money in this context is either taxes or mandatory social insurance fees. But they cluster up here. There's a distinct positive slope to this regression line, and it's positive at the confidence level of 98%. So I think we can say safely that the more money you put in from the public budget into the system, the better it will perform. And well, the ones that perform nicely in the previous diagram, you find them up here. The Netherlands is a well-performing system independently of what measure you use or what dimension you're studying, and the United States, of course, is not well performing. So how should we summarize this? Well, first point, there is a decreasing returns to scale in healthcare budgets. The more money you put into healthcare, the better healthcare you get, but at increasing marginal cost, and that's why we have this concave relationship. And concerning the administrative dimension, there is no difference in average efficiency, so the practically zero slope in the first diagram, but the private solution suffers from much greater risk, and thus the sort of the expected welfare you gain from the healthcare system is lower in the private at the private side. Fourth point, the more public money you put into the system, the better it performs, which may irritate some participants in this debate who sort of by a reflex claim that public money always lowers efficiency. I'll get to this in a moment. And then I'll not show the other computation, but if you do this for the ranking scale, the sort of the ordinal scale instead of the cardinal scale, you will reach similar conclusions. If you restrict attention to OECD Europe, these conclusions still hold, but of course you lose statistical significance because the European countries are so close to one another, both economically and culturally. So I mean, from a statistical point of view, you lose a lot of information. But we can feel fairly confident about these results. So if these are the observations, how should we explain them? Well, sort of the first curve, decreasing returns to scale, that's as expected. I mean, I could explain that before. I showed you the diagram, and nobody would expect anything differently. The sort of lack of average difference between private and public solutions implies that both sides to this debate in a sense, are correct. I mean, there are pros and cons for private and public solutions, and all of these arguments are valid, and they seem to be valid roughly at the same level of confidence, on the aggregate level at least. But then the efficiency variations within the private group should make you somewhat skeptical about the solution. You could say that, okay, the Netherlands is a model case of how you could reform the system and install this managed competition solution. And of course, if you are confident that you end up in the Netherlands position in the diagram, you could go ahead, but you may end up at the United States level if you fail in your reform. So this is a risky project. Well, what about this financial aspect? Why do we see this very strong positive relationship between government financing and efficiency? Well, the explanation is simply that the measures developed at the OECD and which are supported by expertise in the field of health economics are egalitarian. If you want to measure the quality of a vaccination program, the obvious scale is how many % of the target population is reached, and of course 100% is the target, and everybody counts equally, independently of his or her income or status or whatever. So that's sort of an egalitarian touch to all of these measures, and that's what you get if you start from a sort of purely analytical point of departure, untainted by ideological restrictions. So the conclusion from here is that if you want your healthcare system to perform well, the state must be involved in one way or another, either directly by the solution that we have in the Nordic countries, the UK and other Anglo-Saxon countries, or indirectly via the insurance system, where the state pours in money to ensure that everybody is reached. Everybody has equal access to the insurance and to the healthcare services. And you need a state for that, because markets have an innate tendency to produce inequality. You need a state to compensate for that innate tendency. So political measures are necessary, but of course not sufficient. It also requires that those who are in charge of the political system, the government, want the system to perform equally well for all groups in society. But you need, as I said, political measures as a counter weight to this inborn tendency in markets to drift towards increased inequality. Finally, I should say a few words about other studies in the field. Well, I mentioned at the outset that some people have tried to use this longevity at birth indicator and then compensate for obvious factors that may intervene. The OECD have, these people at this OECD secretariat have gone a few steps further here and developed a rather sophisticated statistical apparatus around this. They keep this expected longevity at birth as the sort of the main indicator, and then in order to measure and the inputs, they use the healthcare spending, obviously, but also the socioeconomic environment and lifestyle factors. And then the solutions, administrative and financial solutions, are grouped using principal component analysis, which some of you may have encountered in your previous life, but it's a way of singling out sort of the most important factors and reduce the number of groups from the number of entities from 38 to something lower, which you can handle with the next step, which is data envelope analysis, which is another sophisticated statistical method where you can measure sort of the actual efficiency of a system compared to the ideal efficiency frontier, and the distance between the actual position and the ideal measures the efficiency. As you gather from my description here, this is a very elaborate solution. A lot of statistics goes into the. I'm a bit skeptical about that. For instance, you end up with one group consisting of Iceland, Hungary, and Turkey. And there seems to be very little logic behind a grouping procedure that puts these three highly disparate countries in the same group. But nonetheless, coming to the conclusion of the OECD study, there is no best health system. So we join forces again and say there is no material here to support the argument that any particular administrative solution should be better than the other, which conforms with my second diagram here. There is also a survey by Basu and others on low and middle income countries. So that we leave the OECD area and go out into the rest of the world. It's a meta-analysis. They start out by more than 1,000 publications in this field and reduce that to 100 plus using a number of quality criteria. And they use performance indicators such as sort of patient outcomes, accountability, transparency, fairness, and efficiency. And then they sort of more or less verbally try to condense the conclusions from all these 102 studies. And they summarize their conclusions in these 2 points that you see below. The private sector appears to have lower efficiency than the public sector, resulting from higher drug costs, perverse incentives for unnecessary testing, and sort of the oversupply in the healthcare sector, and greater risk of complications. Whereas the weakness of the public sector seems to be timeliness and lack of hospitality towards patients. So the grand summary for the rest of the world outside OECD seems to be that the public sector-based healthcare system is better in supplying services, but the private solution is better at charming the patients. The reason why I want to talk about it is not that my approach has been particularly sophisticated from the methodological point of view. I mean, anybody could do this with some knowledge of mathematics, statistics, and perhaps some voting theory. But the results, I believe, are so clear, so they should be known to a wider public. And of course, this is a sort of mathematical summary. The conclusions are simply these 2 obvious clusters, no average efficiency, greater spread to the left, and this very strong positive link between government financing and output. once upon a time there was a physicist in the UK of the name Ernest Rutherford, and he commented on the problems of empirical science, in his case physics, and Rutherford once stated that if you need statistics to analyze an experiment, you've probably done the wrong experiment, which is going a bit too far. But I sympathize with his temper. And what I like about these diagrams, you don't really need statistics. You can see with your naked eye that there are these clusters, the average equal efficiency, but the greater spread to the implying greater risk. And this second result, again, using naked eye, you can see that the public solution is more efficient. So I try to live up to Rutherford's dictum in my rather limited use of mathematics and statistics, only the bare minimum necessary. Well, the paper is open access published, so you can pick it up in the European Journal, and here are some selected references. With this I close.
So that's it. Thank you very much. So we're moving into the question and answer period, and as usual we have two kind of audience, people here and people online. So if you're in person, you do exactly like Stefan Svallfors there. You put up your full hand to indicate that you want to ask a question, and Marcus will write it down. And if you have a follow-up, you use the finger. And follow-up should only be follow-ups, not questions. Okay. And online, please use the chat to write if you want to ask a question, and write your name and area of study, so we can get we like to find questions from different areas. And for follow-up question, just follow up to whoever you follow up to. So that's return on that. Let me start by just asking a question of clarification, and I might have missed something. But if I understand it, the division we have here is between public admin systems and systems based on compulsory health insurance. But that doesn't make a distinction who delivers the care. Mm. So like it won't make a difference. Like in Sweden, we have kind of privatized delivery. So, and you won't say anything if that is more or less efficient or anything like that. Mm. So this kind of privatization we have in Sweden is not kind of touched by your study.
Well, these three dimensions, sort of administration, who's in charge, financing, who pays, and the third one, production, who delivers, they are at least hypothetically independent. You could imagine any combination of these ranging from public to private. So in all, 8 solutions. And in fact, there are an infinite number of solutions because, as I said, all solutions are hybrids. So we are not in a binary situation either or, but we are dealing with mixtures. So what I've talked about here is the administration and the financing, and of course. On the third dimension, you could imagine, as we have here in Sweden, a mixture between private practitioners and public primary care, and then at the hospital level we are almost only public. Whereas in other countries you have a greater share for the private sector, like in the United States, for instance. And that's a separate problem. What I wanted to counter in my work here was the tendency to look only at the production dimension and then draw conclusions from there, which is the way the arguments are typically handled in the debate. You make these comparisons between private and public clinics, whatever, and you come up with the result, and these are often driven by economists who support market solutions. So there's a risk of sort of innate bias also in these. And they often leave open the policy conclusions. Sort of the reader of these papers should sort of draw automatically the conclusion. If at the production level the private solution is more efficient, then we should have a private healthcare system. And that's not true. You could.
For the other way around. We can't draw any conclusion from here that we should have, even on the production level, it should be run by the public health.
Well, I leave that open. I haven't.
I thought it was important.
Yeah.
Not in Sweden is that. Also, I wondered about, of course, even the private public is a little bit too rough, because you could have cooperatives delivering it or non-for-profit institutions.
Yeah, those are called private. Those are called private in the OECD statistics.
Yeah.
So government is taxes and mandatory social insurance fees. Full stop. So they don't make this difference between non-profit and for-profits solutions.
They behave differently. Anyway, we should move on to Stefan Svallfors.
Yes, thank you. My question was, what happens if you disaggregate your scale a bit? I mean,
could you speak up, please?
I'm not sure if I can. I think that is like run by.
No, I'm not run by me. It is run by the people over there. So can you put up the volume a little bit?
Yeah. Okay, that's better.
Yeah.
I wonder what happens if you disaggregate your measure a bit. I mean, is the kind of weak or non-existent relationship you find in terms of efficiency between public and private systems, is that because the private systems are more efficient on some of these measures and the public systems are more efficient on other measures, or do you find the same non-relationship if you even move down to the individual indicator level? Have you looked at that?
Yeah, I understand your question. I should admit I did not study that properly in my when I was working with this paper, but my general impression from what it's worth is that there is no such easy link. There are all kinds of links. I mean, geographic links. In Latin America, you may have countries that are performing well in some respects and other. And of course, there is the problem that, as I said, some countries do not have statistics for all of these 37 dimensions. And so you have to interpolate. For countries like Japan, South Korea, they are eliminated on this criterion in a number of dimensions, and so their average is based on a smaller number of indicators that may also affect the outcome. I should perhaps mention that could I get the presentation back, please? A friend of mine looking at this says, well, how do you explain Korea, Japan, Israel, and Netherlands? Why are they so well performing? And I first try to educate him somewhat and say, when you're doing regression analysis, it's a great sin to speculate about the residuals. Okay? But it's very common. You look at the outliers, United States, Lithuania, and what's wrong with these countries? Of course, you need to study that specifically. I mean, all these deviations at this level are noise. We don't try to explain that. But since I got the question, I looked at these countries. What's a common factor between Korea, Japan, Israel, Netherlands, Colombia? I don't know. I think Colombia is a suspect in this context. Well, my candidate for future research would be density of population. Japan has 330 inhabitants per square kilometer. The Israel and the Netherlands around 430 inhabitants per square kilometer, and South Korea, which is the most densely populated of all those, has 530 inhabitants per square kilometer. And my guess would be that this has some effect on the outcome, because we know that geographical distance to clinics is an important factor when people seek healthcare. And so densely populated country has the advantage of providing more suppliers in a limited surface within reach. Within 1 hour, you can reach a much larger number of suppliers. And of course, that would affect the level of competition, irrespective whether you have a public or private system. There are more suppliers to choose between. And we could expect that to have some positive effect on the outcome. And of course, Sweden has 23 inhabitants per square kilometer. So in order to make these countries relevant to Sweden, we should multiply the Swedish population by a factor 20 or so to join this group. And if anyone arguing for the Netherlands to be a model, it should also be prepared to accept a 20-fold increase of Swedish population, which I believe few people will do. That was a long answer to your question.
Yes, thank you. I got much more than I asked for.
So are you happy with that? Okay. Just a small comment. I mean, probably you should use some kind of more refined density measure, because people can live very close by to if there are a lot of urbanization and
yes.
people living out in the countryside.
Yes, but
during the pandemic it was a little bit trickier to know what density measure to use.
Yes, but there is a political ideal that health should be supplied equally for all, irrespective you live in Stockholm or in Bjurs or Säffle.
Very good. Oh, yes, come and sit down here and get a mic. You can sit there.
Hi. Thank you for your presentation. It was really interesting. So I have a question about, you touched a little bit on inequality and access to care. So, for example, in the United States, which we've established is a disaster when it comes to healthcare, there's a huge population of uninsured people, so people who can't even access the care. Is that factored at all into your idea of efficacy? How efficient is a healthcare system if people can't even access it? Was that at all in your thinking or factored into your research? Yes,
there are such indicators in the OECD database. Access is one, and a coverage vaccination programs that would immediately affect a country like the United States, where a substantial fraction of the population does not have access for various reasons. So yes.
Thank you.
And surprisingly few questions, so there's lots of time for questions, but now I give the word to Marcus.
Thank you very much. This is very interesting. I just had a question about sort of what are we measuring here, and how does it relate to the sort of lag times in healthcare provision? So some of the measures that you mentioned at the outset, like longevity or life expectancy at birth, I guess have to do with institutional changes that are pretty slow in changing outcomes. So if we're looking at this graph, are we looking at the outcomes of the healthcare regimes as they are right now, or as they were a couple of decades back? So could you say something about what kinds of effects that have to do with lag times that we could expect? Like if we do a large reform in Sweden right now, wouldn't change longevity right away, but in a couple of decades perhaps, and so forth. So how should we interpret these graphs?
Well, all these indicators are measured at the latest year available. So in most cases 2021, because this process of homogenization at the OECD is lengthy, and they really want to make sure that figures coming from different countries are comparable. So there's a lag of 3-4 years between the delivery and the publication. But then, as you say, it's inherent in some of these indicators that there's an inertia in the the entity that you are measuring. But I mean, longevity, expected longevity at birth at 2021 in Colombia is now. So that's the result of many decisions made 30 or 40 years ago. But I don't think that's a problem for this particular comparison. I mean, there's no reason to believe that public or private solutions should have an advantage or disadvantage from this inertia, because it hits everybody in the same way. So perhaps countries undergoing very rapid social and economic change would suffer somewhat in these indicators that exhibit great inertia. Well, all of these countries are at least middle-income countries. Now, otherwise they are not allowed to join the OECD, so there is a selection already at this point. That goes. I mean, you can argue around each and every one of these indicators. There are problems of measurement, there are problems of comparability between Estonia and Colombia and so on. Do they interpret the instructions coming from the OECD secretariat in the same way in Tallinn as in Colombo? And so not Colombia. Colombo is in Sri Lanka. They try to, I mean, they really make an effort. And sometimes they draw the conclusion that they are not comparable, and then they state that very clearly in their comments to the database. So they, I mean, they exert the maximum care that could be required from them, I would say. And again, all these objections that you can raise, you must relate to the question that we are dealing with. Do we have reason to expect that public or private solutions are penalized by this problem that you are raising? And in the most cases that I tried, the answer was no. It's a good thing that you find such spread here in the left-hand group. There are both middle-income countries and rich countries, and they are geographically spread and so on. So you could expect some elimination of climate effects and so on. So from a statistic point of view, this is a rather ideal population.
Thank you.
Very good. So, okay. Karim. Valdemar, vad satte du på?
When you've been looking at the data, thanks for the talk, it's very interesting. Are there certain areas of the healthcare system that you find are where there are more kind of positive effects from private money, or where they're privatized compared to other areas? Or have you found any patterns like that?
Yeah, I understand the question. Well, no, that's not in the database. I mean, they publish the aggregate budget, then disaggregated with respect to financing sources such as taxes, social security, private insurance programs, etc. So there is no disaggregation with respect to single services captured by the indicators. Some countries may be spending a lot on computer-based tomography, for instance. Well, does that pay? Well, the explanation is often, in those cases, that there is an industry producing tomography apparatus. And so the government wants to favor its own industry. Generally, I mean, based on common knowledge, I say most measures early in life are efficient. I mean, maternal care, vaccination programs for children, and healthcare for children, because that pays off during whole lifetime. Whereas intensive care, when there are 3 or 4 years left of your life, of course, yields relatively little in expected longevity at birth and other indicators. So that's like education, for instance. I mean, there's obvious advantage of investing early in the life cycle.
Thank you. Thank you for your interesting presentation. I'm Valdemar Ingdahl, and I wonder. Often I've heard in the public debate that a privately funded system would favor innovation more. But if I understand your findings, it's actually the public sector that grounds more innovation and opens up for it. Would this be because of its equality, that innovation is given equal to patients, or what influences the result?
Well, the link between profits and innovation is very complex, as you indicate with your question. If we look at the history of innovation during the 20th century, for instance, or even for the 2 last centuries, say since 1800, and ask yourself, which are the major technological steps that we have taken since 1800? Well, I guess most of us would answer the number 1 on that list would be the taming of electricity, because in the year 1800 there was no electricity at all, and now there are very few functions in society that can function without electricity. So there's no single innovation that has penetrated our society as deeply as electricity. And of course, who did the research and technological in the field of electricity? Well, the answer is almost only professors at public universities. There's one exception, which is Michael Faraday, who was a sort of an innovative genius and who produced the first electric motor in the world. But on the whole, including the transistor, by the way, there is some misconception here that Bardeen and Shockley and that group at Bell Labs were the inventors of the transistor, but the actual inventor was Julius Lilienfeld, who was a professor at the university in Poland. And when Bardeen and his colleagues applied for the patent, they were denied that with reference to his patent, which was already accepted. Next, well, let's take a big leap forward. We live in space age. Everything now, communication over large distances, GPS systems for positioning and control and so on. That's all space-based. Well, who started space age? The Soviet Union launched the first Sputnik in 1957. Soviet Union, the most, the horror example of anti-market economics. They were able to launch this, and you can go on. The internet is a public innovation. Then, of course, once the internet solution was there, it was exploited by all kinds of private companies and so on. But the conclusion is that the really large steps have almost always been publicly financed and sort of have been brought about by the public initiative. But everyday innovations, I mean, using these major innovations for consumer purposes, that has often been done by the private sector. I mean, using electronic technology for video cameras, tape recorders, and so on. That was done by Toshiba and American competitors. But even so, even if there is a consumer demand, it has to be profitable in order to justify the investments in innovation. And one particularly important example right now is antibiotics that could be used against organisms with multiple resistance patterns. The private industry is not interested, has not been interested in developing antibiotics for this specific use, because the market by definition is small. You should only use these new antibiotics in extreme cases when all other antibiotics are useless. And so your back of the envelope analysis is that it wouldn't pay to develop it. And now what's happening right now is happening on the basis of state initiatives, and Sweden happens to play a leading role in this international effort to develop antibiotics for this specific. So as you quite correctly imply your question, the idea that the private sector is always better at innovations is wrong. It's better in certain niches that are defined by the profit-seeking motive, but there are large and important niches outside this where the state has a responsibility.
Happy with that? So is there any more questions from the audience? If not, join me in thanking Per for this great talk.
Thank you.
We have some talks coming up. We have next week, September 10th, Marte Mangset, Money Professionals Negotiating Public and Private Wealth. And she is a professor of sociology at University of Oslo and the directrice Centre Universitaire de Norvège at Paris. And September 24, we have Anandi Hattingadi. We don't know what she's going to talk about, but I suspect it's going to be about artificial intelligence. And she's a professor of philosophy. So welcome then. Thank you very much.